Have you ever wondered, what exactly makes a dental implant stay put? Like
Mm.
properly anchored in bone
Mhm.
so someone can eat and speak like normal again. It's this really fascinating mix of biology and engineering, and today we're taking a deep dive into the science behind it. Osseointegration. Our mission today for you is to sort of strip back the layers of the science, materials, mechanics, even what's coming next. The goal is you walk away with the essential bits, a really clear understanding of what's actually important here without getting, totally bogged down. We've got a stack of research, and we're ready to make it click. So, osseointegration, where do we even start? Sounds complex, but it's really the bedrock of modern implants, right?
It is. And what's fascinating, is the core idea isn't new. It was Professor Bronnemark over 40 years ago. He defined it as this direct structural and functional connection between living bone, ordered living bone, and the surface of an implant that's carrying a load. And that fundamental idea, it's still absolutely the foundation today, despite all the advancements we've seen.
Okay, so what are these implants actually made of? I hear titanium all the time. Is that it? Or are there other options? And why titanium?
Titanium is definitely the workhorse. Its biocompatibility is just superior. See, when it hits the air, it forms this layer, titanium dioxide, TiO2. It's dense, stable, super corrosion resistant. That layer is really the key. Now, there are different grades, but mostly we use an alloy, grade 5. It's Ti6L4V. It's got the same great biocompatibility, but crucially, it's stronger. Better tensile strength, better fracture resistance than pure titanium.
Ah, so strength is a factor, titanium strong, but you mentioned fracture resistance. Can they still break? That
Yeah.
sounds, well, pretty bad.
It's rare, thankfully. The incidence is very low, less than 1%. But yeah, if it happens, the consequences are drastic.
What does drastic mean in this context? Like, what happens to the patient?
Well, drastic means the fractured implant usually has to come out. That involves another surgery, maybe bone grafting to repair the site, and then either a new implant or finding a whole different solution. It's a major setback. These fractures, when they do occur, are often down to design or material choice, like using a lower grade titanium in a smaller diameter implant, say 3.75 millimeters, they have higher fracture rates. Or having thinner walls right at the neck of the implant, especially if it's put into really dense bone or just undergoes a lot of fatigue from chewing over time.
Okay, so there's a limit to how thin you can go.
Definitely. The material strength dictates how small you can make the diameter, particularly for the common two-piece implants. Around 3.0 millimeters seems to be the practical limit there. If you need something even smaller for really tight spaces, then you probably look at a solid one-piece design. It's just inherently stronger.
Gotcha. So mostly titanium alloys. Are there real alternatives starting to emerge now?
Yes, things are evolving. Zirconia is one that's a ceramic, ZrO2. It has similar biocompatibility to titanium. The big plus is obviously cosmetics. No dark metal showing through the gums. Patients like that.
I bet.
But while it's much stronger than older ceramics, fracture resistance is still, a bit of a concern, often related to how the abutment part is prepared or if it's not seated just right. A key disadvantage, though, is that zirconia implants are usually one piece. This means they stick through the gum right from the start, permucosal healing, we call it. And that limits your options for correcting the angle later on. We really need more long-term clinical data before it becomes, a routine go-to. Another interesting one, more recent, is rock solid. It's actually a titanium zirconium alloy, Ti01317. It's about 50% stronger than pure titanium and shows really significantly better properties for things like elongation and fatigue strength. This might be a really good fit for those smaller diameter two-piece implants or components that are under a lot of stress.
Okay, that's a really helpful breakdown of the materials. But you said it's not just what they're made of, it's also how they're made, specifically the surface that's critical for this osseointegration.
Absolutely. Critical. The surface properties dictate everything at that initial interface, the molecular interactions, how the cells respond, and ultimately how well the bone forms around it. Those early Bronnemark implants had machined surfaces, basically quite smooth. That was the gold standard for years. But the next generation, the second generation implants, really focused on modifying that surface chemically, topographically to create more roughness.
Okay, wait. If smooth was the gold standard, why make them rougher? Is rougher always better?
That's the key question, isn't it?
Hmm.
There's a pretty strong consensus now that roughening the surface, at least above that basic machine level, gives you a stronger and faster bone response. This is especially helpful in tricky spots, like where bone quality or quantity isn't great, maybe after a sinus lift. It can genuinely improve implant survival rates there. Other benefits could be shorter healing times, maybe loading the implant sooner. But here's the nuance. While some roughness is good, clinical evidence hasn't really shown that any one particular type of rough surface is definitively superior to others.
Ah, so it's not about finding the magic rough surface, just getting it rougher than smooth.
Pretty much. It seems there's a kind of sweet spot, a moderate roughness, that gives the best biological response.
Fascinating. So what's actually happening down at the cellular level? When you put the implant in, how does that roughness help things along?
Right, so picture this. The moment the implant goes in, boom, a whole biological cascade kicks off. First, blood plasma proteins just latch onto the surface almost instantly. Then come the cells, red blood cells, platelets, white blood cells. The platelets get activated and release growth factors. These are like little chemical signals calling in the important bone-forming cells, fibroblasts, osteoblasts. Meanwhile, the blood clot that forms around the implant acts like a scaffold, a temporary framework for these bone-forming cells to migrate into.
Okay, like a construction site scaffold.
Exactly. And here's where the surface texture becomes super important. A micro-textured, rougher surface gives that fibrin clot, the protein mesh of the clot, more to hang on to. It resists being detached. This means the bone-forming cells can migrate right up to the implant surface and start laying down new bone directly onto it. That's what you want.
That's a great picture. So how do we actually measure this roughness to know if it's in that optimal zone?
Yeah, we have specific parameters. The most important one is SA. That's the average roughness measured over a 3D surface area. It's more informative than raw, which is just a 2D line measurement. To give you a feel for the numbers, smooth surfaces are generally less than 0.5 micrometers SAT. Minimally rough is 0.5 to 1.00. Moderately rough, that sweet spot, is about 1 to 2 micrometers, and rough is over 2. Animal studies suggest that in SAV, around 1.5 micrometers seems to be optimal for the strongest bone response. Go much smoother or much rougher, and the response tends to be less robust.
1.5 micrometers. Okay, that's incredibly small.
It is, though it's worth noting the long-term effects of these moderately rough surfaces on the surrounding gum health, and maybe the risk of peri-implantitis, that's inflammation around the implant, that's still something we're learning more about.
Right. Always more to learn.
Mm-hmm.
So given this sweet spot, how do manufacturers actually create these precise surfaces? You mentioned subtractive and additive methods.
Exactly. You can either take material away subtractive or add material on top additive. On the subtractive side, one common method is blasting. Think of it like controlled sandblasting. They use tiny particles, aluminum oxide, although there were some concerns about leaving particles behind, or calcium phosphate, which is resorbable and maybe more biocompatible, or even titanium oxide particles. This blasting creates that moderately rough surface, and it definitely shows better bone integration compared to the old machined implants.
So blasting is one way. What else?
Then there's acid etching. This uses strong acids, sulfuric, hydrochloric, sometimes hydrofluoric, to basically erode the surface in a very controlled way. It creates these tiny micropits, giving a really clean, detailed microtexture. Acid-etched surfaces tend to show better bone-to-implant contact earlier on. This might mean shorter healing times, and some studies suggest better survival rates in tricky situations, like poor bone or for smokers.
Okay, blasting or etching, can you combine them?
Yes, and that's actually very common. It's often called SLA, which stands for sandblasted, large grit, acid etched. You blast first, usually with larger aluminum oxide particles, then follow up with acid etching. This creates a really complex microtexture, moderately rough, and it's well proven to give stronger bone integration than the old machine surfaces.
That makes sense, combining the techniques. Now, what about the additive methods, adding things onto the surface?
Right, so additive means coating the implant. One older method was titanium plasma spray, or TPS. This created a pretty bumpy, irregular surface. It did show increased tensile strength at the bone implant junction compared to machine surfaces, but the clinical follow-up wasn't great. Reports suggested TPS surfaces were associated with more marginal bone loss and more peri-implantitis, so their use has really dropped off significantly.
Interesting. So rougher isn't always better if it leads to other problems. What about other coatings? I've heard of HA.
Yes, hydroxyapatite, HA, coating. HA is a type of calcium phosphate similar to the mineral component of bone. These coatings are often plasma sprayed onto the titanium. They offer some unique advantages, theoretically enhanced bone bonding, maybe faster bone formation, more bone contact. This makes them seem attractive for compromised sites, like areas with poor bone.
But there's a catch.
There is. Concerns linger about the coating potentially separating from the implant or dissolving unpredictably over time, which could actually lead to bone loss. So while the overall clinical reliability hasn't been terrible, there's still controversy about their long-term effectiveness and whether they might carry a higher risk of peri-implantitis. Generally, the trend now favors those moderately rough subtractive surfaces over these very rough plasma sprayed coatings like TPS and HA.
Got it. Any other ways to modify the surface?
One more is oxidation, sometimes called anodized surfaces. This basically involves electrochemically thickening the natural titanium dioxide layer. This process often creates micropores within that thicker oxide layer. These surfaces have shown good results, more bone contact, stronger anchorage than machine surfaces, and even higher success in some immediate loading studies. However, there isn't clear evidence they help soft tissue integration any better, and there's some suggestion that if the anodized surface extends too far up the implant, close to the gums, it might actually attract bacteria and contribute to peri-implantitis.
Okay, so that covers the main ways surfaces have evolved. We've got the materials, the surface textures, but science never stands still. What's next? What's on the cutting edge to make these connections even better?
That's the exciting part, isn't it? How do we push things further? Research is definitely exploring some really innovative modifications beyond just roughness. One area is playing with surface energy. Remember that titanium dioxide layer? We can modify it to make the surface hydrophilic water-loving instead of hydrophobic water-repelling. Even without changing the texture, studies show this can increase bone-to-implant contact, especially early on. It seems to attract blood proteins and cells more readily. Some favorable clinical results are coming out with shorter healing times.
How do they make it water-loving?
One way being explored is using ultraviolet light treatment right before placing the implant. It seems to activate the surface somehow.
Clever. What else?
There's laser etching. This is super precise. Lasers are used to etch tiny microchannels, maybe 8 to 12 micrometers deep, usually around the neck of the implant. What's cool is these channels seem to do multiple things. They might inhibit the gum tissue, the epithelium, from growing down along the implant. They provide little niches for connective tissue to attach into. They enhance bone attachment in that area. And ultimately, they seem to reduce that marginal bone loss we talked about.
Wow. Very specific functions from tiny channels.
It's pretty neat. Then we get into nanotechnology. We're talking surface features not at the micrometer scale, but the nanometer scale, 1,000 times smaller. Lab studies, in vitro studies, show that surfaces with these nano irregularities can increase the response of osteoblasts, the bone-building cells. The idea is they provide even more binding sites for proteins and cells. Some commercial implants are starting to incorporate nano features, but honestly, we still don't know what the optimal nanotopography is for the best biological boost.
Still early days for nano, then.
Relatively, yes. Another approach is adding ions directly into the surface. Fluoride is one getting attention. Incorporating small amounts of fluoride ions into the oxide layer of, say, a grit-blasted implant has shown promise in both animal and human studies, increased bone formation, stronger bonding, especially at earlier time points.
Interesting. Fluoride like in toothpaste.
Similar ion, yes, but incorporated into the implant surface itself. And speaking of adding things, remember the issues with HA coatings?
Yeah, dissolving or separating.
Right. So scientists are developing newer calcium phosphate coatings trying to avoid those problems. One method involves depositing discrete nanoparticles of calcium phosphate. This might enhance bone conduction because of the nanotopography and the biological effect of the calcium phosphate itself. Another approach tries to mimic natural biomineralization, essentially growing bone-like crystals onto the implant surface at body temperature. These coatings might be more soluble and resorbable in a controlled way compared to the old high-temperature HA coatings.
Growing bone on the implant.
Yeah,
That sounds like the holy grail.
It's certainly a very exciting direction. Beyond just minerals, there's also work on adding bioactive proteins. Basically, coating the implant with specific proteins to actively stimulate local bone healing. The big players here are bone morphogenetic proteins, BMPs, especially BMP2 and BMP7. They're osteoinductive, meaning they can actually trigger new bone formation where it wouldn't normally happen.
Wow.
Recombinant versions are already used in some bone grafting scenarios. The challenge for implant coatings is how to attach them effectively and ensure they're released slowly, gradually, at the right dose. Too much too fast could cause problems, like immature bone or even pushing the implant out of place.
Right, delivery is key.
Absolutely. Related to BMPs are other growth factors, cytokines like PDGF and TGF-beta. These are important in normal wound healing. Now, using platelet concentrates, which are rich in these factors, in conjunction with implants, has shown some promise in animal studies, like faster healing, more bone contact. But, and this is important, we don't currently have solid, unequivocal evidence from human trials that coating implants with these specific growth factors gives a clear, consistent boost to osseointegration. More research needed there. It's complex biology.
Okay, so proteins are promising but tricky. Is there anything else on the horizon? Maybe using drugs?
Yes, that's the last category, pharmacologic coatings. A totally different strategy. Use drugs to control how the bone remodels around the implant. Bisphosphonates are a prime example. These are drugs known to inhibit osteoclasts, the cells that break down bone.
The ones used for osteoporosis.
Exactly. So the idea is if you incorporate bisphosphonates onto the implant surface, you might reduce bone resorption right next to the implant and encourage denser bone formation. Early studies look promising. Increased bone density around the implant, higher bone formation rates, better stability, especially in poor quality bone. The challenge, again, is achieving sustained release over the right period. But people are exploring ways, like incorporating them into those biomimetic calcium phosphate coatings or using fibrinogen matrices as carriers.
Okay, we've covered a ton, the biology, the materials, the surfaces, the cutting-edge stuff. Let's pivot a bit. You mentioned earlier something that really struck me. Most implant complications aren't biological, they're mechanical. That feels counterintuitive.
It does, doesn't it? But if you look at the big picture, it really highlights where the focus often needs to be after the implant has successfully integrated. The biological side, getting that bone-to-implant connection, osseointegration itself, it's actually highly predictable now. Success rates are well over 95%. But the vast majority of problems that crop up later, they're biomechanical. They happen after the implant starts taking load, after you start chewing on it, especially within that first year or 18 months.
So the biology works, but then the engineering, the forces cause issues. What kind of mechanical problems are most common?
Well, you can get early loading failures. That's where an implant that was integrated loses its connection to the bone and becomes loose. This often relates to factors like poor bone density to begin with, not enough bone volume, or just putting too much stress on that bone-implant interface too soon. In fact, in the very softest bone types, failure rates as high as 40% have been reported, specifically due to biomechanical overload. The bone just can't handle the forces.
40%. Wow.
Yeah, in those specific challenging situations. But beyond outright failure, the more common day-to-day technical complications are things like issues with attachments for overdentures, the prosthesis itself cracking, maybe the acrylic or porcelain tooth chips or screws loosening. These kinds of technical problems can actually happen more often than biological issues like infection or peri-implantitis. And as we discussed, though rare, the implant body itself can fracture under extreme or prolonged stress.
Okay, and what about that bone loss right at the top of the implant, the marginal bone loss? Is that also mechanical?
That's a really interesting area. Some degree of marginal bone loss right at the crest of the bone is seen around almost all implants. Historically, people talked about maybe 1.5 millimeters in the first year after loading, and then a tiny amount, like 0.1 millimeter annually after that. It's so common, that initial loss, that some older success criteria didn't even count in the first year. There are several theories about why it happens. One early idea was surgical trauma. Maybe the drilling heat or reflecting the gum tissue caused some initial damage.
But that doesn't quite fit.
Not entirely. If it was just surgical trauma, you might expect the loss to be more generalized or happen much earlier, right after surgery. That's not usually what we see. It tends to happen after loading.
So what's the main theory now?
The most widely accepted is probably biomechanical response. It goes back to Wolff's law, adapts to the forces put on it. Think about it. You have titanium, which is way stiffer, maybe 5 to 10 times stiffer than cortical bone. When you load these two different materials together, the stress concentrates right at the top, at the crestal bone. You get this V-shaped or U-shaped stress pattern. So the theory is that a certain amount of bone remodeling or resorption right at the crest is the bone's natural way of adapting to that concentrated stress.
So the bone reshapes itself slightly to better handle the load.
Essentially, yes.
Okay.
And if the strain gets too high, beyond what the bone can handle physiologically, you can get microfractures and more significant resorption. Animal studies do confirm that chewing forces, dynamic loading, contribute to this crestal bone loss.
Okay, biomechanics makes sense. Any other contributing factors?
Another major theory involves the biologic width. Just like around natural teeth, the body establishes a protective cuff of soft tissue around the implant neck, a combination of epithelial attachment and connective tissue. Now, the structure is similar to teeth, but the attachment is different. For implants, the connective tissue doesn't insert into the implant surface like it does into cementum on a tooth root. It's more of a parallel fiber arrangement, a less tenacious pseudo-attachment.
Right.
The hypothesis is, if there isn't enough vertical space for this biologic width to form properly above the bone might resorb downwards slightly to create that necessary space. And indeed, clinical studies tend to show more marginal bone loss when implants are placed in areas with thinner gum tissue.
So the body makes room for the gums. Fascinating. What about the implant parts themselves?
That leads to the implant abutment microgap theory. Most implants today are two-piece systems: the implant body in the bone and the abutment which connects the crown to the implant. There's always a tiny gap, a microgap, at that connection point, and that microgap, which is usually located near or even slightly below the bone level, can become a little haven for bacteria. Microbial leakage can happen. This bacterial colonization right at the bone level can cause inflammation, and that inflammation could contribute to the marginal bone loss we see.
Like a little bacterial reservoir right where you don't want it.
Exactly. Animal studies have shown some correlation between the location of this gap and bone loss. One-piece implants, which don't have this gap, often show less resorption, but it's not perfectly clear-cut. Other studies find inconclusive results. Things like how well the parts fit together, how tightly the screw is torqued, the type of connection, the loading forces, they all likely play a role too. It's multifactorial.
Okay, and one more concept I hear about is platform shifting. How does that fit in?
Right, platform shifting. The idea here is to intentionally use an abutment that's narrower than the implant platform it sits on. So the microgap we just talked about gets shifted horizontally inward, away from the edge of the implant and therefore away from the bone crest. The rationale is that this might shield the bone from the inflammatory cells that gather around that microgap, thus minimizing crestal bone resorption.
Does it work?
Well, several clinical studies have reported better bone maintenance with platform shifting, but other studies haven't found a significant benefit. So the jury's still out a bit. We need more good, long-term, randomized controlled trials to be really sure. It's possible that other factors, like the specific type of implant abutment connection or the implant neck design, might be confounding the results in some of those studies. It might not just be the shift itself.
So many variables. Given all these potential pitfalls, especially the mechanical ones, it sounds like meticulous planning before even placing the implant is absolutely crucial.
Oh, absolutely critical. The whole philosophy when planning implant treatment, especially for replacing multiple teeth, is really about protecting the prosthesis. You want to design things to reduce those undesirable mechanical stresses and disadvantages, aiming for long-term, stable function. And that starts right at the beginning, identifying patient risk factors before surgery.
Like what kind of risk factors?
Big ones are parafunctional habits, grinding, bruxism, clenching. Also, just assessing how strong someone's bite is, their masticatory dynamics. These need to be factored in from day one.
Okay, so once you know the risks, how do you actually design the support system to be stronger and spread the load better?
There are several key things the clinician can control. First, probably the most effective, implant number. Simply using more implants increases the total surface area supporting the prosthesis and decreases the stress on each individual implant and the surrounding bone. Now, for a single tooth, it's usually one implant, obviously. But for bridges or full arches, deciding how many implants is a crucial decision. It's especially critical if you're thinking about immediate loading, putting teeth on right away, particularly in the upper jaw where bone is often softer.
More implants equals less stress per implant. Makes sense.
What else? Abutment positions. Where you put the implants is vital for distributing the load effectively. You want to limit the number of pontics, the fake teeth suspended between implants and a bridge. A common guideline is no more than 2 pontics between supporting implants. And crucially, you want terminal abutments and implant at each end of the bridge section. This avoids cantilevers, which we'll talk more about. The further apart your supporting implants are, the more flexible or bendy the prosthesis becomes, which increases stress.
Right, keep the span short. What about the sides of the implant itself? Does longer always mean stronger?
That's a really common misconception. People assume longer is always better, but remember where the stress concentrates, right at the neck, the crestal area. Increasing the implant length doesn't really do much to decrease that stress concentration. Now, longer implants can provide better initial stability, which is important, especially for immediate loading. And they do offer more total surface area for bone contact, so length has its place. But, and this is really key, implant diameter has a much more significant effect on reducing stress in that critical crestal bone area compared to length or even the implant shape.
Diameter is more important than length for stress.
For crestal stress distribution, yes. Even a small increase in diameter, say just 0.25 millimeters, can boost the surface area by 5 or 10% right where it matters most. This helps dissipate forces better, reduces stress on the bone, and can also reduce the risk of components like screws loosening or fracturing. This is especially important for single molar replacements, which take a huge amount of force.
But you can't just put a huge diameter implant anywhere, right?
No, absolutely not. You need adequate bone width. Trying to force a wide implant into a ridge that's too narrow can actually backfire and lead to more marginal bone loss because you compromise the blood supply or leave very thin bone on the outside. It's a balance.
Okay, number, position, diameter. You mentioned force magnifiers earlier, like cantilevers and grinding. How do those fit into the planning? They sound like major risks.
They are huge mechanical risk factors. Let's take cantilevers. A cantilever is basically a part of the prosthesis that extends beyond the last supporting implant, like a dieting board. These are major force magnifiers. They create significant bending or rotational forces on the supporting implants and the bone. This can lead to bone loss, screw loosening, prosthesis fracture, even implant failure. There's a concept called the anteroposterior AP spread. That's the distance between the frontmost and backmost implants supporting the bridge. The greater that spread, the more leverage you have, and theoretically, the longer the cantilever you can safely have.
Is there a rule of thumb?
A general guideline is that the cantilever length shouldn't exceed about 2.5 times the AP spread. And you'd want to reduce that significantly if you have fewer implants or if the bone quality is poor. Minimizing or eliminating cantilevers is always preferable if possible.
Okay, avoid the diving boards. What about grinding and clenching parafunction?
Parafunction is incredibly destructive. Grinding and clenching introduce forces that are often much higher in magnitude than normal chewing. They last longer, and they're often in damaging lateral directions, creating shear forces. It's strongly implicated in higher rates of implant complications, technical problems like screw loosening or porcelain fracture, increased marginal bone loss, and even implant failure.
So how do you manage that? You can't always stop someone grinding.
You can't always stop it, but you plan for it. For patients with known severe parafunction, the treatment plan gets modified. You might plan for more implants, maybe wider diameter implants, especially in the back. You'd be very careful about the material choice for the teeth. Maybe avoid porcelain, grinding against porcelain, opting for gold or acrylic on one side. And definitely recommend routine use of a protective occlusal guard, a night guard.
Makes sense.
For removable options like overdentures, the patient can simply take them out at night to avoid those damaging forces.
And what about just normal biting force masticatory dynamics?
Yes, that's considered too. Bite force varies a lot between people. Clinicians look at factors like patient size. Gender, men often bite about 30% harder than women. Age plays a role. Older patients sometimes have lower force. Even skeletal structure matters. People with short, square faces, brachycephalic types can generate much higher forces, sometimes 3 times higher than those with long faces. And force is naturally higher in the back, the molar regions, decreasing as you move forward. All of this influences decisions, like choosing wider diameter implants for molars.
It's like personalized engineering for each patient's mouth. So putting it all together, what does this look like for replacing, say, all the teeth in the upper or lower jaw?
Right, applying that protect the prosthesis philosophy. Let's take the edentulous maxilla, the upper jaw, first. It's generally trickier than the lower jaw. Why? Because the bone volume is often less, especially in the back due to the sinuses, and the bone quality is typically softer, less dense. So while just 2 implants might work okay for a lower overdenture, it's really not recommended for the upper jaw. The failure rates are just too high.
So how many for an upper overdenture?
The minimum recommendation is usually 4 implants, typically placed in the front part of the jaw, avoiding the sinuses. And crucially, these 4 implants should be splinted together with a connecting bar for cross-arch stability. You usually place attachments on the bar to hold the denture. If the patient wants a completely implant-supported upper overdenture, one that doesn't need to rest on the palate at all, you're usually looking at 6 implants, and that often requires bone grafting, like sinus lifts, to create enough bone in the back.
Okay, and for a fixed bridge in the upper jaw, one that doesn't come out.
For a fixed maxillary prosthesis, things get even more demanding. You might have heard of the all-on-4 concept.
Wrigley, yeah.
It uses 4 implants, with the back ones tilted to try and avoid the sinuses and engage better bone. While some studies show decent early results, the big risk is that if you lose just one of those 4 implants, the whole prosthesis fails. There's no backup. So a more conservative, maybe more prudent approach generally recommends at least 6 implants for a fixed upper arch. And if the patient has high-risk factors like grinding, strong bite, poor bone quality, You might even plan for more, maybe 7 to 12 implants, often needing significant bone grafting to make that possible, especially if you plan immediate loading.
Wow, 6 to 12. That's a big difference from 4. What about the lower jaw, the edentulous mandible? Is it easier?
Generally, yes, the mandible is more predictable. The bone in the front part, between the mental nerves, is usually very dense and strong. So for an overdenture, using just 2 independent implants in the anterior region is a well-documented and often successful protocol. It's cost-effective. The downside is the denture still rests on the gums in the back, and those posterior ridges can continue to resorb over time.
So 4 is better.
Using 4 implants, again typically placed between the nerves and splinted with a bar, is more common for a bar overdenture. It provides much better posterior support and stability for the denture. Now, for a fixed prosthesis in the lower jaw, the classic Brånemark approach often used 4 to 6 implants placed in that anterior region, with cantilevered sections extending back to replace the molars. And this has shown very good long-term results. There's even a systematic protocol where you mentally divide that front section of the jaw into 5 evenly spaced columns and try to place implants optimally within those for load distribution and hygiene access. The length of the posterior cantilevers, again, depends on that AP spread.
Can you put implants further back in the lower jaw to avoid cantilevers?
You can, yes. Placing implants in the posterior mandible can reduce or eliminate the need for cantilevers. However, there's a theoretical biomechanical concern here: mandibular flexure.
The jaw flexes.
Yes, believe it or not, the lower jaw isn't perfectly rigid. When you open wide, it bends slightly inward at the midline. During chewing, there's some torsion. So if you rigidly splint implants across the front and back of the jaw with one long bridge, that natural flexure of the bone could potentially put stress on the implants and the prosthetic components over time. Because of this, some clinicians prefer to avoid rigidly connecting anterior and posterior mandibular implants. They might opt for unilateral posterior implants supporting separate segments, or just stick to the anterior implants with well-managed cantilevers. It's something to consider in the planning.
Mandibular flexure. Who knew? Okay, that was a truly deep dive, from the tiny surface features right up to planning entire jaws. It's so clear that implant success is this incredible interplay between biology and biomechanics.
It really is. You have the biological response, which is thankfully very predictable now, but then you absolutely have to anticipate and manage those mechanical challenges. That's paramount for long-term success. Hopefully this discussion highlights just how much thought goes into making these things work reliably.
Yeah, absolutely. So thinking back on everything, what really stands out to you? Maybe that fracture rate, less than 1%, but potentially devastating. Or perhaps how those tiny laser-etched channels can actually guide tissue growth.
Both good points. It shows the extremes, doesn't it? The rare but serious failures, and the incredibly subtle innovations trying to improve things at the micro level.
It's this constant balance, isn't it? Innovation meeting clinical reality and precision. We really hope this deep dive has given you, our listener, a kind of shortcut to understanding this complex field. It makes you appreciate how understanding the body, combined with some really smart engineering, keeps pushing healthcare forward. So the final question for you to ponder: what's the next big frontier in biointegration? How will we keep refining this delicate dance between our own living tissues and these engineered materials? Thank you for joining us on the deep dive. We'll catch you next time as we unpack another fascinating topic.